So welcome back. Now we are going to continue with the other free living amoeba. This is slightly different in terms of it is has flagella. So let's get to it. So this is Naegleria fowleri, which causes primary amoebic meningoencephalitis. So PAM. This is a difference between the other ones. These other ones cause GUI. This cause PAM. Primary amoebic meningoencephalitis is much more acute version of the disease. So this is found in freshwater habitats and damp soils and in areas where the heated waters, the swimming pools and aquarium and sewage. But it doesn't really stay in salt water. So you can't find this in salty water. Most cases associated with swimming in warm or heated waters for a few days prior to the onset of symptoms. So I don't know how many of you would be able to identify this place, but I'm not saying this is a place where the parasites are, but a similar kind of a setting could be, especially in tropical setting. However, this is a very rare disease. I mean, to now, since 1960s, in known cases by the CDC, there are about 140 cases, 145 cases in the world, and the survival rate is very low. They're like only known 3 to 4 survivors of this diagnosed cases. So it's quite a notorious infection. So these exist also as trophozoids, and also the trophozoids in this case, they can be amoebic and they can be flagellated, so they can have flagella. And the cyst forms also exist. So there are 3 forms: amoebic, flagellated amoebas, and can be cyst forms. So these amoebic trophozoids have active forms. They're motile. They feed on bacteria and other organic matter, usually undergoes asexual replication and converts to flagellated form when they're deprived of nutrients. And eventually they can encyst to avoid drying or desiccation. The flagellated trophozoids usually are pear-shaped with 2 flagellas, and then usually are non-feeding and they're not replicating. So with the flagellated trophozoids, they're usually non-feeding, as much as they're still called trophozoids. Don't really worry about the nomenclature. But there's in the flagellated trophozoids and non-feeding, there's no replication that goes on and reverts back to a amoeboid form when the nutrients are restored. And the cysts are usually dormant stage, characterized with low metabolic activity, and cysts will convert back to trophozoids when conditions are favorable. But all stages are characterized by a single nucleus with a large karyosomes and no peripheral chromatins. You can see this is a basic life cycle of this free-living amoeba between trophozoid cyst and flagellated form. These are different from GUI causing amoebas, which are acanthamoeba and Balamuthia. These ones are not pointy; they're more blunt ends if you see them, and these are the cysts that you could see in this case. They have lobopodia, broad, blunt pseudopodia, and only the amoebic trophozoids is associated with PAM. The flagellated one is not associated with PAM or the cyst, which is another difference between this and GUI. The nasal cavity, they enter the nasal cavity by inhalation and the aspiration of water after deep dives in these water sources that are containing trophozoites. And they penetrate through the neuroepithelium. They migrate along the olfactory nerves to the brain, and they can take 1 to up to 14 days. This is a description of how that could happen. So, take a deep dive in these waters, and you don't have these, you don't hold your nose. They would get pushed up into the cribriform plate here, and then they would sense by the chemokines that are released by the nerves in the olfactory nerves, and then they will crawl all the way up to your olfactory nerve, and then through this olfactory nerve they go to the brain, and then they start causing they develop suckers and start to feed in the brain matter. So they usually eat bacteria, but when they're into the brain, they start eating your brain matter. So they're also known as brain eating amoebas. So the symptoms resemble bacterial meningoencephalitis. They're characterized by sudden onset of a headache and fever. Remember, this is more acute compared to GUI. And it causes nausea, vomiting, and other symptoms that are related to an increased intracranial pressure And the rapid progression from the headache to fever to confusion and coma, boom, 3, 4, 5 days, dead. So normally they're diagnosed after you're dead, and autopsy is much more common. So it's almost always postmortem, and the prognosis is not good. If you do cerebrospinal fluid, you can do microscopy to look for trophozoids, you could do wet mount preparations, you could even smear the brain tissue, you could see them. An organism can be cultured in non-nutrient agar and see them. So this is an example of this, and these are you would be able to appreciate compared to what you could see in the acanthamoebas. These are 600 times magnification, and their speed of mobility here is 10 times their normal speed. So they're relatively slow than you would appreciate for the speed that they're moving right now in this context. So the treatment, again, the same. These are difficult to treat, very, very rare treatment. You might need to have the people that have survived these, the 3 or 4 survivors that have had this disease, that had to go back and start again speech therapy. They had to go back again and get treated to learn sometimes to walk, depending on which part of the brain has been infected. And the combinations of these antifungals, antibiotics are also required, and especially again, methoxsine and some amphotericin B could also be used in this case. Preventive measure, again, health education, to make sure that sometimes when you go to swim in the swimming pool, you can use nose blockers so that you don't get direct water entry directly into your nose all the time to aspirate. And chlorinate the swimming pools, because they will not be able to survive in chlorinated pools. That's all I had to share with you today. So if you have any questions, this is the time, and I'll be listening to you. Welcome.